Assalamu alaikum and good day. Today we are going to look at a group of lung diseases called chronic diffuse interstitial lung disease and acute lung injury. At the end of this session, students should be able to describe the common chronic diffuse interstitial lung diseases and describe the pathogenesis of common pneumoconiosis, pulmonary edema, and acute respiratory distress syndrome. Chronic diffuse interstitial lung disease is a group of disorder characterized by inflammation and fibrosis of the pulmonary connective tissue. It is divided into 5 major categories: fibrosing, granulomatous, eosinophilic, smoking-related, and others. We are going to look at a few of these. Clinical and pulmonary functional changes are of restrictive lung disease. The problem in restrictive disease is inability to fill the lung with air. Compare this with the problem in obstructive disease, which is inability to empty the lung. If you can't fill the lung, obviously the total lung capacity will be low. The forced vital capacity will also be low, and patients will have dyspnea and tachypnea. Eventually, increased pulmonary vascular resistance will occur, and that will lead to secondary pulmonary hypertension, which will then be leading to right-sided heart failure. The wall of the alveoli is super delicate and thin. The reason you want it to be thin is for oxygen and carbon dioxide exchange across the wall. In interstitial fibrosis, the fibrosis occurs in the interstitium, which thickens the barrier and which then will affect the exchange of gases. Filling of the lung will also be affected because it's hard to expand it. So restrictive problem will occur, which is the inability to properly fill the lung with air. Idiopathic pulmonary fibrosis is a syndrome marked by progressive interstitial fibrosis, destruction of lung tissue, and respiratory failure. It accounts for around 30% of cases of restrictive lung disease. The key features here is fibrosis of the lung interstitium. The etiology is related to cyclical lung injury. When there is cyclical or repeated lung injury, there will be cyclical healing by fibrosis. The injured pneumocytes produce TGF-beta that induces fibrosis. If patients have interstitial fibrosis, we have to exclude other causes such as bleomycin, amiodarone, radiation therapy, and others. Once all the other causes are excluded, then we can call it idiopathic pulmonary fibrosis. Grossly, we can see cobblestoned pleural surfaces due to scarring, just like what is seen in the blue arrow. Subpleural and interlobular septal fibrosis can also be seen. Honeycombing is seen, especially at the orange arrow. This is what it classically looked like under the microscope. There is only one area that is close to normal in this picture. The normal wall of the alveolar sac is very thin and delicate, just like the one near the orange arrow. The other alveolar sac has very thick fibrotic wall, as shown and pointed by the green arrow. This is a picture of high-resolution CT of the lung in idiopathic pulmonary fibrosis. Note the honeycomb appearance of the lung caused by excess fibrous tissue in the interstitium. Compare this with the gross and microscopic pictures we have just seen. Clinically, the patients will have shortness of breath, which gets worse over time because the fibrosis gets worse over time. At the same time, they are going to have cough. Lung CT would show fibrosis, and the fibrosis starts at the subpleural region, and eventually, over time, it can progress to involve the entire lung. Hypoxemia, cyanosis, clubbing is seen later in the clinical course. There is gradual deterioration in pulmonary status, and around 40% of the patients eventually die of respiratory failure. There is no way to remove this fibrosis, so the definitive treatment is lung transplant. Now we look at other types of chronic diffuse interstitial lung disease. The first one is non-specific interstitial pneumonia. It is similar to idiopathic pulmonary fibrosis. However, patients tend to be women and girls, often associated with connective tissue disease, certain drugs, hypersensitivity, pneumonitis, and HIV infection. NSIP has better prognosis than idiopathic pulmonary fibrosis. Another type is respiratory bronchiolitis interstitial pneumonia. It is more common in men and smokers, usually presents in people 40 to 60 years of age, and cessation of smoking often leads to improvement. Another entity is desquamative interstitial pneumonia. It has a strong association with smoking in 90% of cases and clinically presents with gradual onset of cough and dyspnea. The last entity that we'll look at is cryptogenic organizing pneumonia, or bronchiolitis obliterans organizing pneumonia, BOOP. It is a clinical, radiological, and histological entity that is classified as interstitial lung disease. Biopsy shows proliferation of immature bodies or meson bodies and fibrous tissue in the bronchioles. It responds to systemic corticosteroids is excellent. Now we look at pneumoconiosis. Pneumoconiosis is a non-neoplastic lung reaction to inhalation of mineral dust, organic dust, chemical fumes, and vapor encountered at workplace. The main causes are coal dust, silica, and asbestos. Silica causes silicosis, asbestos causes asbestosis, and coal causes coal worker pneumoconiosis or anthracosis. Coal dust is the least fibrogenic particle, and silica, asbestos, and beryllium are very fibrogenic. The particle size determines the site of lung deposition of the material. Particles smaller than 0.5 micron reach the alveoli and are phagocytosed by alveolar macrophages. Pneumoconiosis requires chronic exposure to small particles that are fibrogenic. This has to be small enough to reach the exchange area of the lung, which will then induce the fibrosis in the interstitium. The fibrosis are mediated by alveolar macrophages, which consumes the particles and induce the fibrosis. Exposure to the big particles will be filtered by mucus and removed by cilia of the respiratory tract. The first pneumoconiosis that we look at is coal worker pneumoconiosis. It is a lung disease caused by inhalation of coal particles and other forms of dust. The sources of coal dust are coal mines, large urban centers, and tobacco smoke. There are three types: asymptomatic anthracosis, which is commonly seen in urban dwellers and tobacco smokers, simple coal workers pneumoconiosis, and complicated coal worker pneumoconiosis. Coal workers may also develop emphysema and chronic bronchitis independent of smoking. Simple coal workers pneumoconiosis is characterized by fibrotic areas smaller than 1 cm in the upper lobes and upper portion of the lower lobes. Coal deposits near the respiratory bronchiole produce centrilobular emphysema. Complicated coal worker pneumoconiosis is characterized by multiple blackened scars up to 10 centimeters in diameter, which consists of dense collagen and pigment. There is no increased incidence of TB. Kaplan syndrome may occur. Kaplan syndrome, also known as rheumatoid pneumoconiosis, is the combination of seropositive rheumatoid arthritis and a characteristic pattern of fibrosis. There is increased incidence of lung, colon, and urinary bladder cancer. Coal worker pneumoconiosis usually produce a benign clinical course, causing little damage in lung function. However, in 10% of patients, complicated coal worker pneumoconiosis can lead to increased pulmonary dysfunction, pulmonary hypertension, and cor pulmonale. Silicosis is a common lung disease caused by silicon dioxide or silica. This is the most common occupational disease in the world. It usually presents after decades of exposure, and people at risk include individuals involved in repair, demolitions of concrete structures such as buildings and roads. Silica is very fibrogenic and primarily deposits in the upper lungs. Silica activates alveolar macrophages, which release cytokines that stimulate fibrosis. In the early stages, there is usually small nodules in the hilar lymph nodes and upper zones of the lung. As the disease progresses, nodules coalesce into hard collagenous scars. If the disease progresses further, they may produce progressive massive fibrosis. Clinically, pulmonary function are either normal or only moderately affected early in the course. Most patients do not develop shortness of breath until progressive massive fibrosis occurs. Silica impairs the formation of phagolysosome, especially in the macrophages. So it is the only pneumoconiosis that increases the risk for tuberculosis. Patients with silicosis have double the risk for developing lung cancer. Asbestos exposure is seen in construction workers, plumbers, and shipyard workers. Not only are the workers at risk for asbestosis, even the family members of asbestos workers have an increased incidence of asbestos-related cancer. It causes a number of diseases as listed there: fibrosis in the lung, fibrosis in the pleura, cancer in the lung, cancer in the pleura. Cancer in the pleura is called mesothelioma. The disease depends on the concentration, size, shape, and solubility of different forms of asbestos. Asbestos occurs in two distinct forms, serpentine and amphibole. Amphibole are more pathogenic. It can penetrate deeper in the interstitium, and asbestos fibers prefer to localize in the distal lung, close to the mesothelial layer. Asbestos can act as tumor initiator and tumor promoter. Its oncogenic effects are mediated by reactive free radicals generated by asbestos fibers, and carcinogen from tobacco smoke can adhere on the asbestos fibers. Asbestos workers have five-fold increase in lung cancer. There is also a synergistic effect in that exposure to asbestos and smoking causes 55-fold increase in risk of lung cancer. Asbestos fibers are coated with iron and is called ferruginous body. Golden brown fibers with brown beads on it, the brown beads representing iron. Macrophages attempt to ingest and clear fibers, and this activates fibrogenic mediators as an immune response. Chronic deposition of fibers and persistent release of mediators leads to generalized pulmonary inflammation and interstitial fibrosis. Clinical findings commonly takes 20 years to manifest itself. Dyspnea is the first symptom, associated with cough and production of sputum. The disease can progress to congestive heart failure, cor pulmonale, and ultimately death. It may be complicated by the presence of lung or pleural cancer. Remember, fibrosis in the lung, fibrosis in the pleura, cancer in the lung, cancer in the pleura. Sarcoidosis is a systemic disorder of unknown etiology characterized by formation of non-caseating granulomas in many organs of the body. The most common presentation is bilateral hilar lymphadenopathy or lung involvement, and this accounts for 90% of cases. Diagnosis of sarcoidosis is one of exclusion. You should exclude other causes of granulomatous disease, such as tuberculosis, fungal infection, and others, before concluding diagnosis of sarcoidosis. Sarcoidosis is a disorder of immune regulation. The major histocompatibility complex genes and non-MHC genes have been located on the short arm of chromosome 6. There are genetic risk factors for sarcoidosis. CD4 T helper cells interact with unknown airborne antigens and causes the release of cytokines from T helper cells, resulting in the formation of non-caseating granuloma. The lung is the primary target organ for sarcoidosis. Granulomas are seen in the interstitium as well as mediastinal and hilar lymph nodes. Non-caseating granuloma composed of aggregates of epithelioid macrophages, often with Langhans cells or foreign body type giant cells. Schaumann bodies and asteroid bodies can also be seen. Apart from the lung, pathologic involvement can be seen in every organ in the body. This is just to show how asteroid bodies and Schaumann bodies looks like. Most sarcoidoses are asymptomatic and discovered unexpectedly on X-ray. The X-ray picture shown shows bilateral hilar lymphadenopathy. It can involve almost any other tissues. Other presentations include skin nodular lesion containing non-caseating granuloma, eye involvement as uveitis, splenomegaly, hepatomegaly, and others. Clinically, patients may have elevated angiotensin-converting enzyme or ACE in about 60% of patients. Hypercalcemia can also occur. The granuloma has 1-alpha hydroxylase activity, and this can activate vitamin D. The treatment is steroid. Sarcoidosis can be progressive or may be alternating between active disease and remission. 20% of patients have permanent loss of lung function, and death may be due to progressive pulmonary fibrosis and cor pulmonale. Now we go on to the topic of pulmonary edema. Pulmonary edema is defined as accumulation of fluid in the alveoli of the lungs. This results in poor alveolar gas exchange and breathing difficulties, making it difficult to breathe and exchange oxygen in the alveoli. It can result from hemodynamic disturbances, either from increased hydrostatic pressure in pulmonary capillaries, such as in left-sided heart failure, which is the most common cause, volume overload, and mitral stenosis, or decreased oncotic pressure from hypoalbuminemia, from diseases of nephrotic syndrome or hepatic cirrhosis. It can also be the result of microvascular injury from infection, aspiration, drugs use, and acute respiratory distress syndrome. Morphologically, the lung is heavy and wet, with fluid accumulation in the base of the lower lobes. Histologically, the alveolar capillaries are engorged with fluid accumulation within the spaces, as seen in the picture. There may be hemosiderin-laden macrophages, and also fibrosis and thickening of the alveolar walls. This condition predisposed to infection. Now we move to the topic of acute lung injury and acute respiratory distress syndrome, ARDS. Acute lung injury is also known as non-cardiogenic pulmonary edema. It is characterized clinically by abrupt, significant hypoxemia and bilateral pulmonary infiltrate in the absence of cardiac failure. Although the term acute respiratory distress syndrome is often used interchangeably with acute lung injury, ARDS is the most severe form of the disease. Listed here are the major causes of acute lung injury and ARDS. Sepsis and pneumonia being the most common causes. Gastric aspiration accounts for about 30% of cases, and severe trauma with shock accounts for 20% of cases. We look at the pathogenesis of acute respiratory distress syndrome. Look at picture A. The injury of the alveolar capillary unit may begin at either the endothelial side of the unit or the alveolar side of the unit. The neutrophils either are inside the alveoli or in the alveolar capillaries play a major pathogenetic role and mediate the injury of the alveolar capillary unit. Neutrophils adhere to activated endothelium and migrate to the interstitium and alveoli. They degranulate and release mediators such as reactive oxygen species, cytokines, and proteases. More leukocytes recruited, causing more injury and repeats the cycle of inflammation. Picture B shows the injury leading to increased permeability of the alveolar capillary membrane and pulmonary edema formation. This is often followed by intra-alveolar hemorrhage and deposition of fibrin, causing the hyaline membrane. The destruction of alveolar capillary units leads to hypoxemia. In the acute stage, the lungs are heavy, firm, red, and boggy. Congestion, interstitial and intra-alveolar edema is seen, and inflammation and fibrin deposition is seen. Alveolar walls lined by hyaline membrane, as shown in the arrow, composed of fibrin exudate with necrotic cells. Just remember, the destruction of the alveolar capillary units causes hypoxemia. In the organizing stage, there's a lot of cellular proliferation in attempt to regenerate, and also granulation tissue appears. There's also fibrin exudate organization with fibrosis appearing. All this contribute to hypoxemia. The clinical cause of acute lung injury and ARDS. The patient will present with dyspnea and tachypnea, severe hypoxemia which is not responsive to oxygen therapy, and bilateral crackles. Crackles are often associated with inflammation or infection of the small bronchi, bronchioles, and alveoli. Respiratory failure results from inadequate gas exchange by the respiratory system. There's also diffuse bilateral infiltrate on chest X-ray and respiratory acidosis. The mortality rate from ARDS is about 60%, and resolution of ARDS is ultimately dependent on treatment of the underlying disease state. If it's sepsis, we have to treat the sepsis. So we've covered common chronic diffuse interstitial lung diseases, and we've gone through the pathogenesis of the common pneumoconiosis, pulmonary edema, and acute respiratory distress syndrome. Thank you very much. Assalamu alaikum.